Okay, so welcome everyone to what is one of several webinars being organised this week by Thrombosis UK. And this is part of World Thrombosis Day, which is tomorrow, October the 13th, which, as you know, was the birthday of Rudolf Virchow. Before we start, I would like to thank Joe Jerome and other colleagues in Thrombosis UK for all the hard work they've done to put together an excellent series of webinars. We are also able to do this and offer this free of charge because of our supporters. And if you go into our virtual conference rooms, you will see that there are actually stalls laid out by our sponsors / supporters. None of them have had any say in the content of today's presentations, but they've just supported us to use this platform. Usually each year we will have meetings where, the cancer-associated thrombosis one will maybe have 100 attendees. We've had 1,000 people sign up for this one from 33 different countries. So, we've got a truly international flavour, which I think is amazing. And I think one of the reasons is that we've got such an excellent lineup of speakers. I'm very proud to call both of them friends. I've given them many opportunities to ditch me and many good reasons to, but you're going to hear from two people who are absolutely at the top of their game clinically and with regards research. If I were to look at the last 10 years of cancer-associated thrombosis research, these guys have been at the forefront of it. They've been leading the most pivotal trials, and also not just doing that, working really hard in education, delivering guidelines which are sensible. And, it's a real privilege to have these guys give up their personal time to do this for a small UK charity. So we've chosen topics which we feel are not only topical, but also where there's been a fair change in the evidence. So what we'll do is I'm going to introduce our first speaker. If you have questions, just put questions on the, if you type the questions in and I'll have a look at them, we'll have time for discussion at the end. So I'm first going to introduce Professor Marc Carrier. He is a Professor of Hematology, Thrombosis and Hemostasis interest at Ottawa University. And he is going to update us as to where things stand now with the direct acting oral anticoagulants, or DOACS, in cancer. Marc, thank you very much.
Thank you very much, Simon, and thank you for the kind invitation. It's a great pleasure to be here today to talk about a topic that is really a passion of mine, talking about cancer-associated thrombosis. As you mentioned, Simon, direct oral anticoagulants and a lot of new data. So how do we digest the data? How do we tailor anticoagulation? What type of patients should get a direct oral anticoagulant versus a low molecular weight heparin, and when? Before starting, it's important to have a look at potential conflicts of interest for the presentations. I don't get personal income from presentation and advisory board. My research institute does, and it's used for residents' research and education, but there remain potential important conflicts that you should be aware of. And just as an introduction, what I want to do over the next 30 minutes or so is summarize with you guys the evidence on the efficacy and safety of the different anticoagulant regimen, low molecular weight heparin and DOACS. See how do we digest it, what our clinical practice guidelines are saying, and how do we incorporate that into clinical practice? Is this relevant or not? And how do we tailor anticoagulation for cancer-associated thrombosis? And as we all know, a lot of these folks have a lot of special characteristics that makes it challenging to initiate anticoagulation. So we'll have a look at that as well and try to come up with some guidance by the end of the presentation. So just to make sure we all start on the same foot, as we all know, venous thromboembolic disease is not so common in the general population, but very important. The incidence about 1 or 2 per 1,000, but as soon as you have a cancer diagnosis, you increase the odds ratio by 4, and as soon as you have a cancer diagnosis initiating chemotherapy, you're increasing the odds ratio to 6.5. So just putting these two numbers together, we're no longer talking about 1 in 1,000, but we're talking about 1 in 200. And the cancer journey is complex. It's not only about starting chemotherapy or being diagnosed starting chemotherapy, but often patients will accumulate small risk factors as they go through the cancer journey. They'll be admitted to hospital for complication, have central venous catheter being inserted. They may have surgeries, biopsies, and therefore a big observational cohort study from the UK, with Professor Andrew Cohen and colleagues, have actually shown that if you follow the patients from the time of diagnosis until the end of life, the incidence is much higher than 1 in 200. We're talking about 6 per 100 person years. And that's why you and I as clinicians are seeing so many of these complications. Now, they're not always just the lower proximal, lower limit DVT or PEs, but all sorts of venous thromboembolism, including arterial, are very common in the cancer patient. That's why they need to have attention. They're not only very common, but they're associated with significant morbidity, decreased quality of life for recurrent VTE and for major bleeding complications, but they're also associated with increased mortality. So folks that have cancer, the risk of dying from a thromboembolism arterial venous is about 9%, similar to infection, for example. And that's why it's important to make a diagnosis promptly and to initiate anticoagulation that is effective and safe as soon as there's a suspicion for venous thromboembolism. And therefore, the aim of the talk today is really to have a discussion about what are the different options for acute treatment of cancer-associated thrombosis. We'll specifically look at the latest trials looking or comparing different direct anticoagulants to low-micrate heparin. We'll spend a bit more time on Caravaggio because it was just recently published, and we'll try to put all that together and come up with some guidance for you and I at the end of the presentation. So the evolution of anticoagulant therapy in cancer-associated thrombosis is tremendous, and it's been accelerated over the last few years. We can go back and talk about unfractionated heparin, vitamin K antagonist, low-micrate heparin, the comparison between low-micrate heparin, vitamin K antagonist, or warfarin. Then we all know this was the standard of care. Low-micrate heparin is standard of care for many years. And you can see at the end of the arrow over the past 2-3 years, a lot of data came out comparing different direct anticoagulants to low-micrate heparin, and things are changing. I mentioned that low-micrate heparin was the standard of care for decades. Well, it's based on 6 randomized control trials that has compared low-micrate heparin to vitamin K antagonist. On your left-hand side, you look at efficacy, so it was associated with relative risk reduction of 50%. On the right-hand side, you're looking at safety, so no difference in major bleeding complication. And therefore, since 2003 or so, clinical practice guidelines have been saying, well, maybe low-micrate heparin should be the first line for cancer-associated thrombosis treatment. Now, over the past 2.5 years, we had a number of randomized control trials that have been published. These data have been incorporated in clinical practice guidelines as well. Independent, if you're looking at ASCO, for example, the American Society of Clinical Oncology, ESMO, ESC, European Society of Cardiology, they've all provided recently clinical practice guidelines that include some of the data, but they were not including Caravaggio because it was just very recently published. The only clinical practice guidelines to date that has incorporated Caravaggio is the NCCN guidelines from the United States. And that's the reason why I'm showing them to you, because we'll have a look at how they interpreted the data, then we'll dive into the different studies, and then we'll have a discussion afterwards, is that reasonable or not, and make a decision. So the NCCN panelists decided that DOACS are preferred for patients without gastric or GE junction type of lesions. And they put a little bit more preference to apixaban or edoxaban with categories 1. Rivaroxaban is still reasonable with a category 2A. And they really didn't like the bigotrans so much because of the lack of data. And therefore, they say it should be a lower part in the algorithm if low-micrate heparin is not possible, for example. Okay, so these are the recommendations they've been coming, their conclusions. We'll have a look at the different studies very, very briefly, and then we'll look at how to tailor anticoagulation together. The recommendations are based on systematic review and meta-analyses that pull the data together. And you can see on the top here that if you compare the different DOACS to low microwave heparin, dalteparin for all the trials at the clot regimen, you can see that the different direct anticoagulant was associated with a lower risk of recurrent VTE despite anticoagulation. So that's a measure of efficacy in these trials, but that was not statistically significant. But it came at a cost, an increased risk of bleeding that was also not statistically significant. And not all the different studies had the same impact. So it's important to actually have a look a little bit to the different studies, maybe spend a little bit more time on Caravaggio because it's the latest trial, and maybe changing things or not so much, and at least have a discussion and then go to tailoring. So the first trial, very briefly, is Ocusite VTE cancer trial, large non-inferiority open design randomized control trial, randomizing 1,055 patients to edoxaban, so 5 days of low microwave heparin followed by edoxaban, or low microwave heparin dalteparin at the clot regimen, so 200 units per kilogram per day for the first month and 150 kilogram per day thereafter. There's two things that are different with Ocusite that as a clinician you need to remember. The first thing is they wanted to treat patients for at least 6 months and up to 12 months. So the primary outcome measure are over 12 months. So that's the different of the 6 months we usually think about for cancer-associated thrombosis trial. And the primary outcome was a composite of major bleeding and recurrent VTE. Okay, and then when you look at the primary outcome measure over 12 months, you can see the conclusion is that edoxaban was non-inferior to dalteparin for the primary outcome measure of recurrent VTE or major bleeding. As clinicians, we want to have a look at the component of that primary outcome, of course. So on the left-hand side here, you see risk of recurrent VTE. So that would be your measure of efficacy. You can see that folks that are receiving edoxaban in that case had a lower rate of recurrent VTE. The hazard ratio is 0.7. That was not statistically significant, but that came at a cost of higher risk of bleeding. In the middle, we can see the hazard ratio was 1.77. So folks receiving edoxaban had a higher risk of major bleeding, and that was statistically significant. The second trial that we often refer to is the SELECT-D trial, a fantastic program based in the UK by Professor Annie Young. And it was a more modest type of sample size, so it's not over 1,000 patients, but about 406 patients. And the reason for that is the primary endpoint was the primary goal was to look at feasibility of randomizing patients to DOAC versus low microwave heparin. Remember, as clinicians, this was new. And then to do a second randomization trying to look at secondary prevention. So in the SELECT-D, they looked at rivaroxaban at the DVT and P dosing. So remember, that's 15 milligrams PO BID for 21 days and 20 milligrams PO daily thereafter, or dalteparin at the dose that we talked about. They had a second randomization too. I'll briefly talk about it because it's really important and helpful for clinicians. But the second trial really looked at rivaroxaban per se. And then when you look at the primary outcome measure of recurrent VTE over 6 months, you can see it's similar to what we saw in Ocusite VTE cancer, lower risk of having recurrent VTE if you have or have received rivaroxaban. But that came at an increased cost of increased major bleeding a little bit. That was not statistically significant, but increased risk of clinically relevant non-major bleeding. So remember, ISTH definition for major bleeding is dropping your hemoglobin by 2 grams, critical site, fatal bleeding, intracranial bleeding. Clinically relevant non-major bleeding is a bleeding that you need to seek medical attention or see a doctor or your primary care doctor, but doesn't meet the first criteria or all the criteria for major bleeding. That's important to keep in mind simply because when we tailor anticoagulation, we'll need to pull data of all these different studies to make a treatment decision. The second randomization of the SELECT-D study was recently published in JTH. And I want to mention it because it's important. It's smaller, 92 patients only. They had to stop the second randomization because it was hard to recruit patients. And we know it's hard to recruit patients for secondary prevention because often patients have decided, and clinicians, Professor Noble and colleagues have shown that in their research program, they have a firm decision. So kudos to Professor Young and colleagues to have done this, but they've tried to randomize patients if they had an initial pulmonary embolism or residual vein obstruction. If the initial clot was a DVT, they were randomized to receive rivaroxaban or placebo. And if the initial clot or the index event was a DVT and they didn't have residual vein obstruction on ultrasound after 6 months, they were kept on anticoagulated. If you look at the first group, because the higher risk group, you can see that rivaroxaban seems to still have a role, or anticoagulation seems to have a role, because the hazard ratio is 0.32, so very high in folks that were randomized to placebo. And there was no major bleeding between the two groups, and the clinically relevant non-major bleeding was very similar. So probably, again, a role for synovial prevention beyond 6 months based on that. Admittedly small data, but important data. And then for folks that did not receive anticoagulation because they did not have residual vein obstruction, again, very small number, but the risk of recurrence was small. And that's sometimes something I use in clinical practice when I have a patient, for example, high risk of bleeding, to help me decide what's the risk-benefit ratio of anticoagulation. The last but not least trial is the Caravaggio trial. I'll spend a bit more time on Caravaggio, not because it's necessarily better, but because it's newer, so it's important to understand the data a little bit. So it's the largest of the randomized control trial, over 1,000 patients randomized to dalteparin again, or apixaban, DVT or PE doses. That would be 10 milligrams PO BID for 7 days, then 5 milligrams PO BID thereafter, and then followed for 6 months. The primary outcome measure was recurrent VTE. And then the secondary outcome measure was major bleeding. Major bleeding definition is slightly different because they also included folks that required procedure or urgent surgery as part of their major bleeding definition. Now I'm showing you the baseline characteristics because you obviously have read Okusai and SELECT-D many times, and I'm sure you're all expert with SELECT-D for sure. But when you look at the baseline characteristics, they're very similar regarding age and gender. Maybe a little bit less incidental DVTs and PEs, about 20%, compared to about a third for folks in Okusai VTE cancer, and a little bit more in SELECT-D. When you look at metastatic, then they didn't really report metastatic disease compared to SELECT-D and Okusai VTE, but recurrent advanced or metastatic was 68%. And what you can see is most of the folks also received anti-cancer treatment. Now, when you look at the primary outcome, so remember, this was again similar to Okusai VTE cancer. There was an open label, non-inferiority trial design, randomized control trial. And then when you look at it, the primary outcome, folks receiving apixaban had a lower rate of recurrent VTE, similar to SELECT-D or Okusai VTE cancer, that met the criteria for non-inferiority, did not meet the criteria for superiority. So apixaban is non-inferior to dalteparin for the management of cancer-associated thrombosis with an outcome of recurrent VTE. Most of it seems to be driven really by a lower recurrent PE over time. You can see here, lower risk of having recurrent PE in folks that receive apixaban compared to dalteparin. We don't know if these were incidental or symptomatic yet. I'm sure we'll have post-hoc analysis on that, but that was not reported in the main paper. And what's different with Caravaggio is the no difference in major bleeding. So remember, we saw a slight increase with SELECT-D, a statistical increase with Okusai VTE cancer. When you look at major bleeding for apixaban, there are no difference between the two groups, really. A little bit less bleeding, just a one event different, but a little bit less with apixaban. Now, we'll come back to that in the next few slides, but on our mind has always been, well, is GI bleeding a real concern? And a post-hoc analysis of Caravaggio, specifically looking at gastrointestinal major bleeding, comparing the two, showed no difference. Similar to what we saw for SELECT-D, there's an increase in clinically relevant non-major bleeding, a difference, an absolute difference of 6% that was not statistically significant. But it will be important to look at the component and the types of bleeding, because you and I need to make a decision if we can anticoagulate in these patients and with what in the near future. So if you look at these three trials, I think DOACS are a good alternative to low-molecular heparin for managed patients with cancer-associated thrombosis. The DOACS are associated with low rate of recurrent VTE, but some of them with higher major bleeding, a little bit more clinically relevant major bleeding. And now you and I, our job is to decide, is this based on tumor type, other characteristics? Is this differences in baseline population? What should we do to tailor anticoagulation? How do we decide which anticoagulant to use and what dose? So this is what I use in clinical practice when I see patients. The first thing is I think about efficacy and safety, of course. We just spent a few minutes on that. And the second thing I'll think about is tumor type. We'll come back to that in a minute. Presence of intracranial disease, metastatic disease, or primary brain tumors, drug-to-drug interaction, and of course, because Professor Noble is the moderator, but it's also because it's the most important thing, patient's perspective needs to be taken into account, and often will make a change in the decision of what we decide at the end of it. So let's start with tumor type. Remember, we said that major bleeding was increased with folks receiving edoxaban compared to low microrate heparin no-QSI VTE cancer. Well, you and I as clinician wants to have know, well, what type of bleeding was that? It doesn't seem that the difference was related to fatal bleeding or intracranial hemorrhage between the two groups, but the disproportion of major bleeding happening in folks receiving edoxaban was really for upper GI bleeding, okay? You can see here 3.8% versus 0.6%, so excess major bleeding with edoxaban was mainly due to upper gastrointestinal type of tumor. Then the next question, well, who's bleeding? So this is a post hoc analysis from OQSI VTE cancer, again, stratifying patients according to their tumor type. Is it gastrointestinal or other types of tumors? On the left-hand side, you have patients that were labeled as gastrointestinal type of tumors, and you can see this is the time to major bleeding analysis. You can see the hazard ratio was 4-fold increase in folks receiving edoxaban in that arm. So it looks like folks with gastrointestinal tumors were more likely to have upper GI tumors, upper GI bleeding, and therefore we need to be mindful of that. It was somewhat similar in SELECT-D. Remember, SELECT-D, there's not that many patients, 406, but not a whole lot of major bleeding, so the differences are not as important. But when you look at the type of major bleeding, it looks like it was happening from the gastrointestinal tract as well. It's also important to remember that the DSMB for SELECT-D asked the investigators to be very mindful of folks with gastric and G junction during this trial conduct, probably because they saw a slight increased risk of major bleeding in these patients. So that's important for us to keep in mind. It's a little bit different for Caravaggio. We talked that the secondary analysis did not show any difference for GI. I highlighted that on this slide. The only small difference may be with genitourinary type of tumors, but that's important to keep in mind because that might be a type of patients that you need to be mindful of. So when you look at genitourinary type of tumor, there was slightly increased for major bleeding as well in OQSI VTE cancer. When I looked at the clinically relevant non-major bleeding in SELECT-D, there was higher rate of hematuria in folks that received rivaroxaban. And then it's the same thing when you look at clinically relevant non-major bleeding in Caravaggio. The two most type of bleeding were upper airway and genitourinary. So these types of the things that you need to keep in mind, but maybe these tumor types you need to be mindful of. Now, your question that you have, if we specifically looked at upper GI tumors, having a reflection, is it a type of drug or is it based on the type of patients that were included? We'll never know the answer to that. Obviously, apixaban has been shown consistently throughout their program that they seem to be relatively safe for gastrointestinal type of bleeding. But when you look at the different types of tumors and the proportion of these types of tumors that were included in the 3 trials, there's differences as well. And that's based because these trials are heterogeneous and they're not stratified by the type of tumors. And therefore, you're bound to have disequilibrium between the tumor types. And the reason why I'm saying that is maybe we need to be mindful of that when we make a treatment decision. The second thing is the presence of intracranial disease, so metastatic or primary brain tumors. And the reason for that is because very few patients were enrolled into the 3 randomized control trial, and actually they were excluded for Caravaggio. So we need to have a look at other types of data, and often not so good data, observational data. So if you have a patient with metastatic disease, for example, and you need to have, you have a new indication for anticoagulation, there's not randomized data to help you out. There's a systematic review and meta-analysis that was published a few years ago in JTH saying, you know, these are heterogeneous group of patients, low microrate heparin, vitamin K antagonist, lots of troubles with potential bias. But as clinicians, you know, you need to have something to work on. And this is somewhat reassuring that if you have intracranial metastatic disease, excluding renal cell and melanoma, the highly vascular type of tumors, the risk of bleeding on anticoagulation doesn't seem to be different than folks not anticoagulated. It's a different ballgame if you have gliomas or primary brain tumor, because this would be associated with high risk of bleeding, but probably also a higher risk of recurrence. So sure, the risk-benefit ratio is different. That's also important to keep in mind. If you're wondering, is there any data? I've been talking about low molecular weight heparin vitamin K antagonist data. Is there any data with DOACS? Well, the same group from Boston, Jeff Zwicker and colleagues, have published a small observational cohort study, again, with a lot of limitations, 67 patients with primary brain tumors and 105 with intracranial metastatic disease. But the data is reassuring. So for primary brain tumors, there is no difference, or there's no patients with primary brain tumors on DOAC that had an ICH. And then when you look at intracranial disease, there's no difference between low molecular weight heparin and the different DOAC in that particular study. So small, some limitations, but something that you need to consider when you make a treatment decision. What about drug-to-drug interaction? Well, there's a lot of potential drug-to-drug interaction, because although DOACs have less drug-to-drug interaction compared to vitamin K antagonists, they have more drug-to-drug interaction compared to low molecular weight heparin. Strong inhibition or induction of CYP3A4 and glycoprotein P may increase or lower the level of the different DOACs. You're wondering, well, is that clinically relevant? Should I care about it? You're right that it's a little bit of a theoretical risk associated with them, but there's a little bit of data coming out, none of them in cancer patients, none of them with chemotherapy. This is a small cohort study of 213 patients, propensity score match patients with on DOACs for atrial fibrillations and some drug-to-drug interaction. You can see there's an increased risk of major bleeding when there's a constant drug-to-drug interaction. So something to be mindful of. And this recently was published in JAMA Internal Medicine, looking or comparing folks that, again, were on the DOACs and receive an antibiotics, one that has a drug-to-drug interaction versus one that does not. And you can see there was a small but statistically significant greater risk of 30-day admission for major hemorrhage in folks that received the drug-to-drug interaction. Obviously, these are small cohorts, still lots of meditation. More data is coming, more data in cancer patients coming. But for the time being, I think it's important to remain mindful because of this data. And if there's an alternative without drug-to-drug interaction, maybe we should consider it. Patient perspectives is the most important. Professor Noble and his colleagues have done this in the area that low molecular weight heparin was a standard of care. And you're probably well aware that when patients are coming to see us with their clots, they don't see themselves as a clot patient. They see themselves as a cancer patient first and foremost. So the first thing on their mind is, Marc, do not change anything with my anti-cancer treatment. The second is efficacy and safety. And the last is route of administration. And patients really understand if you have to use a parenteral versus a normal agent. Sometimes you have to go back and forth during the cancer journey, and they understand that if you're following these different steps, and I use that every day in my clinical practice. They actually did that again alongside with Select-D, just to see, is this changing now that we have rectal anticoagulant? And it's more or less the same thing. Of course, a tablet might be desirable, but in the context of cancer, a parenteral anticoagulant, if it's needed, is nothing to overly worry about if you're following the three different steps that we talked about. So at the end of the day, what are you and I having to make a decision on? Well, I think, and this is my own, and we'll open up the discussion after Professor Khorana's talk, but I think DOACs can be the preferred agent for a lot of patients with cancer-associated thrombosis. There's good data with apixaban, edoxaban. There's good data with rivaroxaban as well. But I think we need to be mindful of tumor type and bleeding. So upper GI tumors, luminal tumors. If there's a uretery type of tumors, you need to be mindful of that. GI toxicity, nausea, and other things. Drug-to-drug interactions, I think it's fair to have lexicom or a web type of drug-to-drug interaction just to double check, because patients with chemotherapy have multiple different agents over a prolonged period of time. There's maybe a little bit of data out there that maybe there's some drug-to-drug interaction, but firm data is still missing. So until we wait, maybe that'd be the safest thing to do. And obviously patient's preference, and that often leads you back to a discussion about what the patient really wants. So what I wanted to do is just to make sure that you're aware that venous thrombosis is a frequent complication in patients with cancer-associated thrombosis. We have new data with all sorts of fantastic drug, and that's just more tools in the anticoagulant toolbox to manage cancer-associated thrombosis. It's not a one dose fits all. And you need to talk to your patient, but also look at baseline characteristics and try to come up with the right risk-benefit ratio for you and your patient. Thank you.
Thank you so much, Professor Marc Carrier, for an excellent talk. And I can tell you it has generated plenty of questions, which I look forward to moderating on after our next talk. So it gives me great pleasure to introduce our next speaker, who is Professor Alok Khorana, who once again is an outstanding researcher. In fact, he even has an eponymous risk assessment tool, which is often used in my clinical practice. And once again, he is right at the forefront of cancer-associated thrombosis research, as well as being a very accomplished oncologist. So Alok, it gives me great pleasure to introduce you. And you're going to be talking about the prevention of thrombosis in ambulant cancer patients receiving systemic therapies. Thank you.
Great. Thank you, Simon, and thank you to everybody who's taken time out of their busy days to join us. And a very happy Canadian Thanksgiving to my co-speaker, Marc Carrier, who's taken a holiday, time out of his holiday today to join us. You heard a great deal about the treatment of cancer-associated thrombosis, and certainly that's a very important topic. But equally important, I think, is to understand that we may not need to get to treatment if we are able to successfully prevent VTE, particularly in the ambulatory cancer population, and particularly in the setting of systemic therapy where most of these clots seem to occur. These are my disclosures. I'll leave them up for a second. I think most relevant to today are Janssen Bayer and BMS, with whom I've either done research or consulting work related to clinical trials. So you've heard already from Dr. Carrier about the scope of the problem. This is a highly prevalent event in cancer patients. These are rates in cancer patients compared to non-cancer patients. As you can see, astronomically higher rates in the cancer population compared to the non-cancer population. And although both of our talks today focus on venous thromboembolism, I think it's important to recognize that arterial thromboembolism is also quite prevalent in the cancer population. We have a great set of data published just a couple of years ago from a group in New York looking at US national data sets describing a cumulative 6 months incidence of about 5%, 2% risk of MI and a 3% risk of stroke for patients newly diagnosed with cancer. So in addition to the burden of venous events, cancer patients also carry the burden of arterial events. And certainly these events have consequences for patients. Mortality is one of them, as Dr. Carrier already discussed. The combination of venous and arterial events accounts for nearly 1/10 of all deaths in patients with cancer. Again, these are good performance status patients receiving outpatient systemic therapy. So these are not hospitalized patients. These are not patients with significant comorbidities. And there's an indirect association of thrombosis with cancer that we don't fully understand. These are data published recently by Kuder and colleagues describing the risk of mortality in patients with or without VTE. As you can see, VTE patients have a greater risk of mortality, even when you balance out for all the known factors associated with cancer mortality, including the stage of cancer, the type of cancer, and the type of systemic therapy regimen. It's not just about mortality. Morbidity is worsened as well. Particularly, there's an increased risk of hospitalization. There's an increased duration of hospitalization when patients are hospitalized. And all of this adds up to a substantially greater utilization of healthcare resources per patient. These are US numbers, but I'm sure numbers outside of the US are very similar as well. Now, having said all of that, it's important to understand that the risk of VTE is highly variable. So not all cancer patients are at risk, similar risk of VTE. And in fact, even within cancers, there's substantial changes in the risk of VTE. Here's one example. We're talking just about lung cancer, and this is mostly adenocarcinoma patients. And even within that landscape, if you look at rates of VTE in patients with lung cancer that carry the ALK mutation, the ALK mutation, the risk of VTE in our study that we recently presented is about 43%, as compared to about 20% in patients with EGFR mutant cancers and down to 17% with wild type cancers. And even if you look at 6%, this is over the natural history of their illness, if you look at just 6-month cumulative VTE rates, again, these are all lung cancer patients with adenocarcinoma. You're looking at 15%, nearly 16% for ALK mutant cancers, compared to 8 and 9% for EGFR mutant and wild type cancers, respectively. So just to acknowledge that there's a substantial variation in risk between individual patients with cancer. Cancer therapy is changing quite rapidly. I'm an oncologist, so I see that in my clinical practice. 5 years ago, we used no immunotherapy, and now immune checkpoint inhibitors are being used across the board in a variety of different solid tumors and liquid tumors. Here's data from our institution at the Cleveland Clinic, looking at close to 1,700 patients who received immunotherapy for over a 5-6 year time span. And as you can see, very high rates of VTE, about 24% of these patients eventually developed a DVT or a PE. But even with contemporary systemic therapy, with immune checkpoint inhibitors, the overall survival was affected. So even in people who are getting these wonderful new drugs, which are supposed to work so well in solid tumor patients, if you're a cancer patient and you're getting in an immune checkpoint inhibitor and you get a blood clot, your survival's worse than if you don't get a blood clot. And this, this is very consistent with data that we saw with chemotherapy. And the hazard ratio in our study was 1.22. Median overall survival is about a year with VTE and 453 days without VTE. And again, if you hone in on one type of cancer population, just melanoma patients receiving immune checkpoint inhibitors, and these are patients who have benefited greatly from immune checkpoint inhibitors. No VTE versus VTE, you see substantial differences at 1 year survival. And you see risk of VTE quite high. At 12 months, it's about 10%. In patients who are receiving double immunotherapy, it's close to 20% in this population. So the bottom line is there are many different types of risk factors that influence the risk of VTE in individual cancer patients receiving systemic therapy. We talked about the type of cancer, the histology, the grade, the initial period of diagnosis, the oncogenic mutations, the treatments that we give patients, surgery, hospitalization, chemotherapy, immunotherapy, even supportive care stuff like erythropoiesis stimulating agents, blood transfusions are associated with an increased risk. Patient-related markers such as older age, African-American ethnicity in the US, comorbidities are all associated with the risk. And there's a whole list of biomarkers that have been published already or are currently being investigated that are also predictive of the risk of VTE. How do we bring in all these risk factors into a single risk score that could be predictive of the risk of VTE in this population? About 10 years ago, we developed a risk assessment tool that brought in at least the 5 most important variables. The most important, of course, is the type of cancer. So we classified patients with very high risk of cancer, such as stomach and pancreas cancers, and those patients get a score of 2. Patients with a high-risk site of cancer, such as lung, lymphoma, GYN, or GU, get a score of 1. And then 3 components of the complete blood count, a high platelet count, a low hemoglobin, or a high white cell count, each get a score of 1. And then a high BMI is associated with a score of 1 as well. In our initial studies, we showed that if you had a low score for the development of VTE, so a score of 0, the risk of VTE was less than 1%. If you had an intermediate risk between 1 and 2%, your risk of VTE was around 2%. And if you had a high risk, this is around 2.5 months, you had a symptomatic VTE risk of about 7%. And this was roughly the same in the development cohort as well as the validation cohort. Since this original paper, multiple investigators across the world have looked at validating this risk score. A partial list is shown here. Overall, about 46,000 patients have been investigated with this score. Our most recent validation in the US population, about 6,000 patients, was just published. And one of the things we've learned from these multiple validation studies is that the risk can't be quite neatly categorized into these low, intermediate, and high risk, but that the risk essentially rises with each point that you get across the score. And so one of the discussions that the cancer and thrombosis investigator community has had is, should the high risk cutoff be set at 3 or should it be set at 2? And if you go to the first validation study that was led by Jihan Ai and Ingrid Papinger out of Vienna, the cumulative VTE rates in this prospective study was about 10% at 6 months. And if you look at a recent meta-analysis of about 28,000 patients who had 6-month follow-up, the VTE incidence in the first 6 months was also around 9%. So about 9-10% rate of VTE at the 6-month time frame for a score of 2 or higher. And many patients would consider this to be high enough that you don't need to get to 3, that starting at 2 is high enough already. This is not the only risk score that has been developed. The group from Vienna that I mentioned earlier, Pabinger and colleagues, recently published in Lancet Hematology a different version of assessing risk using a Normogram, which is shown over here, that takes into account just 2 simple risk factors, the D-dimer and then the type of cancer. And then depending on the D-dimer level, and then depending on the underlying risk from the type of cancer, you get a certain number of points, which leads you to a specific 6-month cumulative incidence. And they showed in both their development and validation cohorts a higher positive predictive value in identifying patients at higher risk. A different score that looked at this was the clinical genetic risk score called TickOnco, which in addition to taking into account clinical risk factors, also has taken into account multiple genetic risk factors that are listed here. And their predictive value compared to the original score is also shown to be higher in this study. All told, there's several different risk scores that are now available for clinical use. I've listed them here from a commentary that accompanied the Pabinger paper in Lancet Hematology. Unfortunately, many of these have not yet been validated. The Vienna score has probably been the best validated since they used an external validation data set in their sample and were able to show and improve positive predictive value. But just predicting risk isn't sufficient with risk scores. You also need to be able to predict benefit from thromboprophylaxis. And that has been demonstrated primarily with two recent trials of using risk-adapted prophylaxis. And I'll talk about that next. Before I get into sort of more of this evidence, I just want to point out one unique population, which is patients with multiple myeloma. This is a small population of cancer patients with this very specific disease, but has a very high risk of developing DVT or PE, particularly in the era of treatment that started with incorporating IMiDs, which are immune modulatory agents, thalidomide and lenalidomide. There are now 2 published and validated scores saved for patients specifically with myeloma and an IMiDs, and IMPEDE, which includes IMiD therapy as a variable, but also looks at risk outside of using IMiDs. I don't want to get into details, but just to acknowledge that multiple myeloma has its sort of own set of risk factors and characteristics, and you can add up these risk factors with either one of these scores, and you can use them to recommend prophylaxis in this population in the higher risk group. And I guess advanced notice that at ASH, one of my former trainees, Raj Chakraborty, will be presenting a third myeloma risk prediction tool called PRISM. So lots of action happening in this very unique field. Let's move on to treatment or prevention of VTE in cancer patients. I want to point out, although we won't get into it today, that there's actually 3 different settings in which VTE prevention can occur. There's major cancer surgery, and data for this has been around for a good 3 or 4 decades. Patients with major abdominal or pelvic malignancies that undergo a major surgery benefit from immediate postoperative prophylaxis as well as extended postoperative prophylaxis. A second setting is hospitalization, where there are no cancer-specific data, but there are data from the acutely ill medical population demonstrating benefit when cancer patients are admitted with, say, pneumonia or COPD exacerbation or some type of sepsis or infection. They would benefit for inpatient prophylaxis. But most of cancer-associated VTE occurs in the outpatient setting, between 75 and 80%. And so you could be perfect at post-surgical prophylaxis and in hospitalization prophylaxis and still not prevent up to 80% of cancer-associated clots. And so many recent trials have focused on this population, the outpatient systemic therapy setting. Those clinical trials are listed here, and I'll get into details of a few of them. The 2 largest studies that addressed this in the low molecular weight heparin era were PROTECT and TickOnco, both led by Professor Agnelli from Italy. And both are very similar study design, taking a bunch of different types of patients with solid tumors and randomizing to placebo or a specific low molecular weight heparin. As you can see from these 2 curves, both of these studies met their primary endpoint statistically. So there was a reduction in VTE with outpatient use of daily self-injections with low molecular weight heparin. But as you can see here, the event rates were very low because these were not risk-adapted populations in the way I just described risk assessment to you. And so because they were not risk-adapted, event rates were low. Event rates in the placebo arms are between 3.5% and 4%, and in the drug arm were between 1% to 2%, which leads to a very high number needed to treat. So to prevent one VTE, the number needed to treat is around 50 across these two clinical trials, which means that 50 patients need to take a daily self-injection for up to 6 months to prevent one of them from needing a daily self-injection for up to 6 months, which clinically doesn't make a lot of sense. If you took any of these trials and applied risk-adapted prophylaxis concepts to it, here's an example with PROTECT. If you look at all patients, rates are 3.9% down to 2%, included a bunch of patients with a score of 0, 1, or 2. The event rates are even worse here, 3 down to 1.5%. But if you focus on the high-risk population, which at the time was 3 or higher, it's 11% down to 4%. And that dramatically changes the number needed to treat, 50 for the overall population, about 77 in the low and intermediate risk population, but down to 15 in the high-risk population. And this number needed to treat of 15 is very similar to what we use for post-surgical prophylaxis and inpatient prophylaxis, where it's accepted to be a standard. We reported a pooled analysis of prophylaxis in patients with a score of 3 or higher that was published a few years ago. And the risk reduction for VTE with prophylaxis was 0.4 and highly statistically significant. But this was based on 2 retrospective analyses of prospective trials and then 1 prospective trial that was incomplete. So not the strongest evidence, although definitely proof of concept. Last year, we made more advances with the single issue of the New England, where 2 randomized trials, one led by my co-speaker today, Marc, and one led by myself, Cassini and Evert, were published in the same issue, along with an editorial that accompanied it. I'll walk you quickly through the study designs of both these trials. They're very similar with sort of one key difference. Evert first was basically newly diagnosed patients or cancer patients progressing, starting new systemic therapy and a score of 2 or higher, randomized to apixaban 2.5 milligrams twice daily or placebo for about a 6-month time frame. Cassini, similar solid tumors or lymphoma, starting a new systemic therapy regimen, score of 2 or higher, randomized to rivaroxaban or placebo. The one key difference was in Cassini, we asked for a baseline ultrasound before patients were randomized. And we found about 4 or 5% of patients actually already had a blood clot, and those patients were not randomized, which reduced our event rates while on the trial. And we also had screening for VTE while patients were on the clinical trial. Results of Evert are shown here. VTE rates were dramatically reduced. The score would have predicted about a 10% rate of cumulative VTE at 6 months, which is exactly what happened. 10% down to 4%. PE rates were diminished from 16 events down to 5 events. That's a 2/3 reduction in risk of pulmonary embolism, which I think all of us would agree is a very clinically meaningful endpoint. And then mortality rates were no different. Number needed to treat to prevent one VTE was 17, consistent with what the post hoc analyses of the other trials had shown, but at the cutoff of 2 or higher. In Cassini, because of the baseline ultrasound, we did not actually see a separation of the curves until a little bit further in the curves. And so the p-value for the primary endpoint was not significant. If you looked at events during the intervention period, the hazard ratio was 0.4, which was in fact significant. Number needed to treat was a little bit higher, 26, but still lower than the non-risk adapted clinical trials. We also included a bunch of thrombotic events that as secondary efficacy endpoints, and we just published that data in Thrombosis Hemostasis Open. And if you look at up to day 180 analysis, the number needed to treat drops to 21. If you look at the intervention period, which is the time frame that patients are actually taking rivaroxaban or placebo, which was pre-specified, then the number needed to treat drops to 17. This includes prevention of arterial events, which was the major expansion when we look at secondary endpoints. In Cassini, we also saw fewer deaths in the rivaroxaban arm, and the pre-specified composite of the primary endpoint plus all-cause mortality was significantly lower with rivaroxaban 23% as compared to placebo at 29%. The opposite of efficacy in this population, particularly in primary prevention, you don't want to give patients a bunch of bleeds, even if you are able to reduce clots. And for both AVERT and Cassini, major bleeding was increased by an absolute risk of about 1%, not statistically significant for Cassini, marginally statistically significant for AVERT. I think we should accept that point estimate because these studies were not large enough to be powered sufficiently to look at major bleeding. But if we accept those point estimates of 1% absolute increase in major bleeding, number needed to harm, which is the opposite counterpoint to number needed to treat, is quite high, about 100 or so for both these clinical trials while patients were taking the drug. Where there are trials, there are meta-analyses, and here's one that we participated in looking at DOACS for primary prophylaxis. As you can see, risk ratio for oral VTE and for symptomatic VTE quite favor using primary prevention in this setting when combining these two trials in a risk-adapted population. And is it cost effective? You can look at these graphs, and I'm not sure I fully understand how cost-effective graphs or figures are generated. But the bottom line is that if you go by quality increases, these were 94% cost effective at the threshold of $50,000 per quality adjusted life year. If you looked at higher risk patients, so score of 3 or higher, then there was even greater benefit in terms of cost effectiveness. So yes in meta-analyses and yes in cost effectiveness as well. You can see the benefits to patients that were shown in these trials to be incorporated into guidelines now. ASCO, ISTH, and ITEC all updated their guidelines after the publication of Cassini and AVERT. And all of these now either suggest or recommend that high-risk patients defined as a score of 2 or higher starting a new systemic therapy regimen may be offered prophylaxis with either apixaban or rivaroxaban or low molecular weight heparin according to ASCO, and similarly according to ISTH and ITEC as well. So now that these trials have sort of demonstrated benefit, we need to move to a new phase of public health advancement, which is implementation. At the clinic where I practice, we put in the risk score as an electronic medical record alert. So if you have a patient with a high score, those are automatically identified using the patient's type of cancer and their CBC. And then initially we offered a baseline ultrasound to these patients for a score of 3 or higher. Now that the prophylaxis data has come out and has been incorporated into guidelines, we're changing this alert over to recommend prophylaxis. Another very interesting model is the Vermont model that was published in JCO Oncology Practice earlier this year, that actually creates a structure of a risk assessment tool as well as a pharmacy evaluation tool, and then ends up with a referral pattern for solid tumor patients starting a new systemic therapy regimen, where VTE education is offered to all patients, and the patient is also offered a meeting with a thrombosis specialist to discuss drug and duration of VTE prophylaxis. This takes away the burden of adding sort of the prophylaxis discussion to oncologists, away to a consult service that sees all patients starting systemic therapy, identifies high-risk patients, and then meets with the high-risk patients personally to recommend prophylaxis. And this model has been very successful. They've had 2 years of post-implementation now, as shown here. And as you can see, prior to their implementation, they had very low rates of VTE education. They bumped up to about 95%. Referrals to hematology were offered to about 71% of patients that were high risk, and about 94% received VTE prophylaxis, which frankly is the best prophylaxis implementation model that I've seen in the past few years. So I'll stop here, but to just reiterate today's discussion, cancer-associated thrombosis is a big clinical problem, unacceptably high burden, prevalent even with newer drugs and with newer molecular testing, and associated with bad outcomes for cancer patients, increased risk of mortality, increased risk of morbidity, increased risk of hospitalization. It's important to sort of celebrate wins when we get them. We've made a lot of progress over the past half a decade or so. There's novel candidate biomarkers, there are improved risk prediction approaches, and most importantly, there's now a new paradigm for primary prevention, as shown by Cassini and AVERT, using a risk-adapted approach. New guidelines now recommend primary prevention, and we really need implementation science approaches to advance these findings and to reduce the public health burden of cancer-associated thrombosis. Thank you very much for your attention, and I guess we have a few minutes for questions.
Thank you very much, Alok, and it gives us, we have about 15 to 20 minutes for a discussion and for some questions. And thank you to those who have sent questions in. And they're very much clinically relevant questions, which I think reflects our audience. Just first quick one. In your clinical practice, what is your cutoff for DOAC? DOAC use depending on platelet count. So what's your kind of your threshold when you wouldn't use a DOAC? Can I ask you, Marc?
Sure. It's a very interesting question, and the discussion we'll have will likely change over time because as everybody's aware, there's different threshold for DOACs in the different trials, and the threshold is slightly different if you like to compare the details of, for example, locus-site VTE cancer versus Caravaggio. I usually feel very comfortable with full dose anticoagulation with platelet counts over 50. But the point is well taken that the bulk of the data or the clinical experience that we have is mostly with low molecular weight heparin for the time being. Having said that, the data that we have is observational, often retrospective, often non-comparator or indirect comparison, so not the best data, but we often feel a bit more comfortable with low molecular weight heparin, especially in folks that have moderate or severe thrombocytopenia. So what I'm getting at is, I think for the time being, we feel probably a bit more comfortable with low molecular weight heparin in these patients, but there's no real reason why we wouldn't use DOACs, other than maybe the half-life of some of the low molecular weight heparin would be shorter. So I think the data will be coming at some point of the use of DOACs in that particular subgroup of patients. But for the time being, I feel comfortable with any anticoagulants if the platelet counts are over 50. If it's less than 50, then it depends on the time since the index event. If it's a large, if it's a large clot, less than 30 days, then I tend to push dosing of anticoagulation a little bit more, maybe with some platelets if possible to try to bring it up. If it's more than a month, then the intermittent dosing of low molecular weight heparin or holding a day or two of low molecular weight heparin while waiting for platelet recovery would be reasonable. There's an ISTH SSC recent communication on management of thrombocytopenia. Bethany Samuelson was leading that project. So that would be something to refer to if you have questions. Again, this is just guidance because, as I mentioned, the data is not the best and not very strong. But that particular guidance is recommending low molecular weight heparin specifically due to the lack of data with DOACs.
Okay, thank you. So the next question I'd like to ask, and this has been raised by a couple of people, if we have someone who is on a DOAC for cancer-associated thrombosis and compliance is good, and they get a recurrent VTE, what would your advice be? Alok, let's start with you.
Yeah, that's a tough question because, again, it's sort of an evidence-free zone. ISTH had a guidance statement on that, but it's a little bit old at this point because most of the data on recurrent VTE. So this is the question around recurrent VTE while patients on appropriate anticoagulation. I think a general sense. First of all, I think this occurs rarely. So let's acknowledge that. In the DOAC era, about 90 to 95% of patients will not have a recurrent VTE and will not have a major bleed. And I think that's a massive win for cancer patients. We're talking about a small niche of patients who may have recurrent VTE on anticoagulation. Like I said, there's not a lot of data. Most of the data that exists comes out of case series from large institutions that see a high volume of these patients. But even those case series are 20 patients, 30 patients, 40 patients. I think the largest is about 70 or 80 patients. So non-randomized single institution case series is sort of the amount of evidence that we have to judge this on. A good rule of thumb is to switch your class of agents. So if they're on a DOAC, switch to a low molecular weight heparin, for instance. If you're sure that they're being compliant with anticoagulation. If they're on a low molecular weight heparin, maybe switch to a DOAC or go up empirically on the dose of the low molecular weight heparin. And Marc, I think in one of your papers you recommended going up by about 25% or so, and that's it's made up, but everything around this in this setting is kind of made up. So that's a good rule of thumb that I tend to follow. So either switch your class of agents And if you're on low molecular weight heparin, empirically go up on the dose by 25%, assuming that there's no ongoing bleeding contraindications. And then as a final step, if these are not possible or if patient recurs while on it, then consider putting an IVC filter in. But really only put an IVC filter in if somebody's holding a gun to your head.
And from the, sorry, you threw me on IVC filter. I just had a little mini stroke. From the perspective of levels, you know, people always like to know levels. Is there a role for checking DOAC levels or checking anti-10A levels in your low molecular weight heparins? Mark?
Simon, so these are tough questions, of course, and as Alok mentioned, we're evidence-free zone. So I agree with Alok that the data is scarce, and it's hard because it's counterintuitive to say if you have a failure of DOACS to switch to low molecular weight heparin when you know that, for example, in the treatment trials, DOACS were associated with a lower risk of recurrence compared to low molecular weight heparin. But it may be some things like where the absorption might be, I think this is where you're going, the absorption might be an issue, maybe there's some colitis or something that may lead to, maybe a parenteral agent might be desirable. So that might be a fair case. There's I should say not a trial, but a study ongoing from Marcello Denizio and colleagues in the Netherlands looking at failures of DOACS and low molecular weight heparin. And what they're recommending as part of that study is to switch to low molecular weight heparin, but a higher dosing. So going directly to 120% dosing, for example. This is, again, just what people think around this issue. For your question specifically about levels, I'm not overly, so levels don't mean too much clinically. They may be reassuring to clinicians saying, well, it's not overly high or it's not overly low. But remember that levels have never been shown to predict risk of recurrence or major bleeding. So if I have a failure, I don't tend to do levels on a regular basis. I tend to do a level if I had to escalate the dose of low molecular weight heparin more than twice, just to reassure myself that the anti-10A is not through the roof. But I don't tend to use it too much to tailor anticoagulation in that setting, simply because I'm not sure what the level means.
So, question now, there's a couple of regarding the different types of DOAC and which ones you use. So one very simple question, which is, which one do you guys use? Do you use rivaroxaban 10 milligrams or apixaban 2.5 BD as prophylaxis? So people are interested in knowing what your practice is. Alok?
So at our institutions for treatment, we switched over to rivaroxaban in about late 2018 when the SELECT data and the Hokusai data came out. The reason we used rivaroxaban at the time was that the data for Riva and edoxaban came out at the same time. But in the US, at least, we try and avoid admitting these patients. And the best way you can avoid admission is not to have to give them low molecular weight heparin at all. And edoxaban has this lead-in period of a few days of low molecular weight heparin before you transition to the dose. Whereas Riva, you could just get them started on a starter pack. So that's what we decided to do in late 2018. And we've continued thus far. We've reanalyzed our data now that we have a historical cohort comparison where we used to only give low molecular weight heparin. So between 2014 and 18, we did only low molecular weight heparin for about 94% of patients. And then in late 2018, we switched over to Riva. And I think we have a poster at ASH coming up, but our rates look very decent, both in terms of not having major bleeding and having reduction in recurrent VTE. So we are very comfortable with that decision. And at this point, we're not changing over, we're sticking with Riva. And then for prophylaxis, also, we chose Riva, one because our clinicians are familiar with it, and another because it's, it's a once-a-day drug as opposed to a twice-a-day drug. But you could argue, the opposite of that. I think the apixaban results in Caravaggio were very decent and, did not have the GI bleeding rates that you saw with the Riva and the edoxaban data. and the avert data was more significant in the prophylaxis trial. So you could certainly argue I'm not pushing for one over another. You could argue both sides of that, but in our practice, we've been doing Riva.
Marc?
So from a treatment point of view, I really use all three. Depends on the setting and things we didn't have time to mention, but drug-to-drug interaction might be different from one DOAC to another. For example, if they already had low molecular heparin lead-in, these types of things may make me choose one over the other. So I don't really have a personal favorite for treatment. I have to admit that recently I've been using more apixaban for treatment, given the Caravaggio data. But I've been using all three molecules. From a prophylaxis point of view, I've been using, people need to know I'm biased, of course, because I helped to lead the AVERT trial, but I've been using apixaban 2.5 BID. It's been well tolerated, and people seems to be doing very well on it. We're happy with the results we're seeing. Having said that, I think most of the, but having said that, I think RIV10 is also fine. I think at the end of the day, it's small differences that will make you decide one versus the other. So Alok mentioned, once a day, drug-to-drug interaction, at therapeutic dosing, do you need to take it with food or not? Is that a problem? These types of things, but I think all molecules are more or less this, very effective.
So, I think the message that we're getting here is that whilst, we feel that, both these drugs are, completely fine, there are nuances, and actually we're heading far more towards individualized care, taking into account a lot of these.
I think that's absolutely right. And, between 2003 and let's say 18 or so for a period of 15 years, we had no individualization care. We just said everybody has to be on low molecular heparin monotherapy for 6 months because of the clot data and then sort of the marginally significant catch data. And I think now there's true individualization of care. I think for some people you can use Riva, for some you can use apixaban, for some you can use low molecular heparin. It's not that low molecular heparin is totally out of the picture. I think there are clearly patients with, let's say, I'm a GI oncologist, so my population is a lot of patients with gastric masses or esophageal masses. In those patients, I don't feel safe using a DOAC, and I will preferentially use a low molecular heparin. So I think there's definitely been a individualization of treatment that allows for better care for our patients.
I think we have temporarily lost Simon, so I would just step in. I'd like to stress that I am not medically. Here he comes back, thank goodness. Okay, Simon, back over to you.
I do apologise, my Wi-Fi dropped suddenly. That might be because I'm leeching off my neighbour's Wi-Fi, but you don't know where I'm staying. So the question was creatinine clearance of 25. Would you favour a particular agent? Marc?
Why do you always pick me for the hardest questions?
I could ask Jo, but she's not an expert on that.
I'm on mute.
So this is a fantastic question that we get all the time in clinical practice. It's important to be mindful that folks with creatinine clearance of less than 30 were excluded from all the randomized controlled trial, but these patients happen all the time. I have to admit that given that the dosing of the DOACs, especially front end, like for apixaban 10 BID for 7 days or rivaroxaban 15 BID for 21 days, these are big doses of the different directal anticoagulants. So sometimes I feel I'm actually mindful of using them early on to avoid maybe higher levels or bleeding complications. So maybe I would use a low molecular heparin. In that particular case, I would maybe use or favor a low molecular heparin that is bigger, so less dependent on renal clearance, at least for the initial phase, and then consider a directal anticoagulant afterwards. It's not based on evidence. It's my own practice, and it depends on where you practice around the world too, because the product monograph will differ from one country to the other. But for the initial lead in, when you have big doses and the creatinine clearance is low, I tend to avoid the DOACs, and then after a few weeks, when the risk of recurrence is lower, I feel maybe a bit comfortable doing the usual dose.
Okay, so we've got 5 minutes left.
The only thing
so
I'll add to that, Simon, so if I can add one comment to that, which is that, so in the CATCH trial, which was a trial of tinzaparin versus warfarin for the treatment of acute VTE in cancer patients, we published a separate subgroup analysis just in the renal insufficiency patients. And I think the biggest takeaway for me from that subgroup analysis was that people with renal insufficiency tend to clot more, so there's more recurrent VTE, and they tend to bleed more. So more major bleeding and more recurrent VTE in the renal insufficient group, regardless of using warfarin or low molecular heparin in that trial. So I think this is a sick population, and we have to be very, very careful and monitor them very carefully, no matter what agent we use.
Thank you, Alok. So there's another question came, which I think is very interesting, and I'm going to ask Alok to answer it. This person has said, data from Cassini did not show a significant decrease in VTE at 180 days, whilst the VERT was positive in terms of benefit. How do you reconcile these differences in the trials? Do we need to wait for more data before widespread implementation of DOACS routinely in thromboprophylaxis in high-risk cancer patients?
Yeah, so that's a great question, and often comes up, and I often get to pick to answer it since Cassini was a trial that I led. I think so. There's several answers to this question, and let me just get through the major points here. One, these data are not in isolation. They're in the context of multiple prior randomized trials of low molecular heparin, all of which showed, and in fact warfarin, all of it showed a reduction in VTE events with an anticoagulant used prophylaxis. So Cassini and Evert are simply in a long line of clinical trials going back to the early 90s, where Marc Levine had that first trial with warfarin in thromboprophylaxis, down to the very large trials of PROTECT and SAVE-ONCO. There are trials specifically to pancreatic cancer that we did not address today, but FRAGEM and CONCO. And all of these trials, SAVE-ONCO, all of these trials consistently have shown that using low-dose anticoagulation for prophylaxis does in fact reduce the risk of VTE without an increased risk of major bleeding. That's been consistent across all of these trials. So I think it's not that we need more data. I think we have to look at all of the cumulative data that's accompanied these two trials. The second is the unique feature about Cassini and Evert was not that they used prophylaxis, because that's been done before, but that they used risk-adapted prophylaxis. And so did you see higher event rates? And the answer is yes. The key difference between Cassini and Evert, as I pointed out earlier, was this use of baseline ultrasound, which is not standard of care. But we had done that in a prior clinical trial. When we designed Cassini, the data for DOACS in treatment was not there. And so I was anxious about giving DOACS to people who may already have a clot. And so that was the primary reason we introduced this baseline ultrasound, which is not clinically standard of care. And we found a good 4 or 5% of patients already had a clot. Those patients were not randomized. You could very easily argue that if those patients had not had the baseline ultrasound and had just gone on to receive prophylaxis or no prophylaxis, that the event rate would have been higher, which would have increased the power of the study to find statistical significance. And then a third point I would make is that it's not that the results of Cassini are inconsistent. So there was a reduction in VTE. It's just that because events occurred pre-randomization and there was a high rate of discontinuation because of early mortality and cancer progression and so on, that we did not achieve statistical significance. But the trends are all in the exact same direction as with Evert. So I don't feel like these studies are inconsistent. I think they're highly consistent, and they're very consistent with what's been shown previously.
Thank you, Alok. So, folks, we've run out of time now, but I think this has been an excellent 1 hour, 15 minutes. Once again, I would like to thank our two speakers for giving up their time. Marc, I'm very mindful that you should be with your family today, so please do apologise to your lovely wife and send her my regards. Alok, thank you for taking time out of your clinical day. I know it's the beginning of the day, so you've got the pleasure of doing a full day's work now as well. Can I just once again say thank you to Joe and thank you to all our sponsors. Thrombosis UK is a very small charity of which I'm one of the trustees, and as with every charity, financially COVID has made things less comfortable for us. So if you are looking to do any fundraising and you're thinking of an organisation to support, you know, certainly think about Thrombosis UK. It's very much about serving our patients, looking after our patients, but also supporting education and research. So on that point, I'm going to leave you. Thank you both, Marc. Thank you, Alok. I hope to see you soon. And good afternoon for those of you who have joined in. Take care.
Thank you very much.
Thank you, everybody.
Thank you very much.